So the first one is the tongue to hard palate, which is DNT. And typically the tip of your tongue when we say these things is somewhere in the area of the incisive papilla to make these sounds. And there's ways that this can be corrected, some surgically. And I put these 3 slides in to show you why sometimes this DNT sound can become a problem. Most placing doctors that I work with like to have the implant placed lingually in the socket, and that's okay. Sometimes though we'll find that the implant is placed lingually in the socket, and actually the trajectory is lingual to the very much lingual to the incisal edge of the teeth, to the point where when we make a prosthesis, as you see in the right picture, that the prosthesis actually covers the incisive papilla. Now, I know that it's not always possible to perfectly place an implant so that some of the incisive papilla isn't covered, but I think the goal would be to try to get to a point where once the final prosthetic is made, that we can at least have that area thin enough so that making the DNT sounds isn't quite as much of a problem as it would be if we were not able to relieve material in that area and have a substance of acrylic or zirconia there covering the incisive papilla. So there are ways that we can correct that, though, even if if an implant is placed in that lingual area where the appliance would cover the incisive papilla. And one of them is, first of all, just to grind the material away, and we want to try to do this in the provisional so that we can duplicate it in the final. Grind material away enough so that that speech with the DNT sounds improves. And or along with changing abutment heads if it's possible. If it was a 0-degree abutment and the placement of the implant was in the picture like you see in the middle picture, we might want to get that implant trajectory or the screw trajectory aimed more towards the lingual of the incisal edge. And using an angulated abutment facing forward can do that for us. So once that happens, the goal of being able to thin the appliance out and improve speech in that area is more possible. And so we can end up with more success in correcting the DNT sounds by doing that. One thing I forgot to mention when I started was if you have questions, we'll entertain questions at the end of this process. You can put them into the chat box as you have questions, and we will address them at the end of the program, as many as we can. So moving forward, the incisive papilla area is an important group of sounds that we want to try to have the ability to not cover with thick restorative material. And this is an example. If you look at the picture on the left, the little yellow post that you see within the orange circle is the trajectory of the implant, and you can see how far lingual that is. And we have had to deal with these problems. Sometimes more so with freehand implant placements than with implants placed with a guide, because with the guide, when we plan cases, we try to plan our trajectories like you see pictured on the right side picture, with the implant trajectory closer to the lingual of the anterior teeth. And ideally, we want that access hole to be 3 millimeters, approximately 3 millimeters from the incisal edge. If we were to measure lingually from the incisal edge, 3 millimeters lingual to the incisal edge, and that's where the screw access hole would be. So with that measurement, we are able to control the size of the framework or the appliance on the lingual side in the anterior. The picture on the left shows how far away we are with the placement, the trajectory of the implant. So what that means is where you see that yellow post or yellow indicator, our appliance has to be 3 millimeters lingual to that for strength. So on the left picture, if we go 3 millimeters lingual to that position with our appliance, it's going to cover most of the incisive papilla. And on the right side picture, if we go 3 millimeters, it's going to leave some of that incisive papilla exposed. Thereby creating the ability for the patient to speak the D and T sounds. And this is what we would do in the planning area when we do this. This is from a live case that we've done. The picture on the left gives us the least ability to correct the DNT sound. The picture on the right gives us the best ability to correct the DNT sounds. The only way to fix the position on the left to bring the screw access hole more to the facial is to get an angulated abutment and aim it forward so that the screw access hole exits in the cingulum area of the tooth like you see in the right picture. We can't do any more than that. I know that when we do these cases, there are going to be compromises, but the picture on the right gives us the best chance for the least amount of compromise. Okay. So the solutions to DNT, apart from changing abutment heads, are if the patient in their provisional has this issue. First of all, as much as possible, the placing doctor, the surgeon, should be cognizant of this issue and how it can be avoided by placing the implant in a position where this sound can be executed properly once the prosthesis is made. Mechanical solutions to it are, as you see in the bottom picture, we can take a burr and we can take the appliance and we can thin it out and shape it little by little until we see the patient's speech improve to the point where we have grounded enough that that the sound improves. If we can grind it enough to correct the entire DNT sound, that's good. But we have to stop grinding when we start to compromise the strength of the appliance. And in the provisional, that's going to be a little thicker than in the final. So when we reach the final, we can actually, most of the time, make the final appliance a little thinner in that area to help us. So grinding just the lingual behind the anterior teeth in the provisional to correct this is a simple way to start to attack this problem. The next solution is try to make the footprint of the appliance, as you see in the top picture, the part that is over the ridge, as narrow as possible. Keeping in mind that we have to have 3 millimeters lingual to each one of those holes where the cylinder of the appliance is, just for strength. But by keeping the footprint smaller, we expose more of the palate, and the tongue has, more ability to find the correct areas that needs to touch to say sounds.